Hi everyone. My name is Kim. I've been asked by Ella to present everyone a talk about the pros and cons of embryo genetic testing. So thank you very much, Ella, for the invitation. Quick shout out to also Casey for a couple of the last minute changes to the talk. Now, first of all, I'm a scientist. I'm not a clinician. So my thoughts on the talk comes from a scientific rather than a medical point of view. So the main talk consists of three main areas, the first of which is what is embryo genetic testing? As a scientist, we love the use of acronyms. Why? Because it helps us simplify very complex words when we try to explain it to other people. Also, to help us remember certain complex words that sometimes that we also forget. The second part of the talk, I'm going to show a video of how the embryo is prepared for genetic testing. The take-home message that I'd like everyone, when they finish with the talk, is to see how much stress is being actually placed on the embryo during embryo genetic testing. And then the third and final part is, should all patients have embryo genetic testing? The pros and cons, the advantages and the disadvantages of this use of technology in the IVF laboratory. As a history buff, I always like to talk about the origins of something. I always feel that understanding how things started gets us a better understanding of how things work. So in the very beginning, it was called Preimplantation Genetic Diagnosis. The world's first babies were born more than 30 years ago with this technology, where two sets of female twins from two separate couples who had X-linked diseases underwent genetic testing screening of the embryo. This technology was then upgraded in terms of its wording to PGS, which stands for screening. The idea is that we were screening for aneuploidies, in other words, embryos with the incorrect number of chromosomes. What we know is that embryos that have the incorrect number of chromosomes don't implant. In other words, they don't result in a pregnancy. And if they do result in a pregnancy, often they either miscarry or they're born with some form of defects. This whole first generation of technology was recoined PGS 1.0. Now, the first generation of this technology was actually very limiting. The analogy that I always like to use when I try to explain this to people who are trying to understand genetic embryo testing for the first time is the movie Howard Iron Man 2. I'm a bit of a Marvel buff. In it, Tony Stark, aka Iron Man, he's actually dying from the palladium that is powering his Iron Man suit. He comes across a video clip left for him by his late father, Howard. In it, Howard describes how he's come up with this wonderful new concept of an unlimited source of energy. But the problem was that he was limited by the technology of his time, so he wasn't able to develop it. So that analogy is basically the same concept with the very early days of embryo genetic testing. We had this beautiful idea of being able to screen embryos, but the problem was we were limited by the technology that was in place at the time. The technology that we used was a process called FISH, which stood for fluorescent in situ hybridization. The reason why it was limiting was basically of the 24 known chromosomes in the human body, FISH could only detect anywhere between 5 to 9 chromosomes at any one time. Now, why is that an issue? It meant that you needed to redo the test multiple times, which leads to inefficiency. It increases the error rate. It takes longer to do. And more importantly, the overall cost increases. What we were finding in the scientific community was that papers were being published that the PGS was shown to be the dark days of this technology, because patients that underwent PGS 1.0 actually had worse outcomes compared to patients that did not have their embryos tested. So obviously the next improvement came along was PGS 2.0. This is where for the first time, all 24 chromosomes were able to be analyzed at the one time. There are actually 3 competing technologies. I'm not going to go into details about those 2 because that's probably in a talk in itself for another day. But what we were able to do was that we were able to improve the efficiency of the testing of embryos. So you'd think by this time, the concept of embryo screening was a beautiful one. We evolved the technology to being able to analyze all 24 chromosomes at the one time. What could possibly go wrong? So this is a screen grab of Apollo 13, where Tom Hanks, aka Neil Armstrong, discovers that there's a problem with the spacecraft that he was flying to the moon with. That's the same issue that we were discovering in the IVF laboratory. By the mid-2010s, there was an increased awareness that euploid embryos, in other words, embryos that were supposedly having the correct number of chromosomes, were either not implanting, or if they were implanting, were resulting in miscarriage, or at worst, pregnancies with abnormal outcome babies. And the vice versa. Aneuploid, in other words, embryos that had the incorrect number of chromosomes, when they were re-examined with the technology, they were actually discovered to be quite normal. It was realized that embryos may not be 100% euploid or 100% aneuploid, that there might be actually a mix of both normal and abnormal cells. This is called embryo mosaicism. It's best demonstrated by the diagram that I've got here. The embryo on the left-hand side is what we call a euploid embryo. In other words, cells in it are all normal. The aneuploid, the embryo where all the cells in it are abnormal, is the diagram in the middle, which is the red embryo. Whilst the embryo on the far right-hand side is a mixture of both, a mosaic embryo. So why is mosaicism important when it comes to embryo genetic testing? It's because it can lead to false results. The first of which is what we call a false positive result. This is where the test results that come back as telling us that the embryo is abnormal, when in truth, the embryo was more likely to be normal. In this scenario, the laboratory would have discarded the embryo instead of transplanting it back into a patient. The second type of false result is what we call the false negative. This is where the test results come back as normal, when in truth the embryo is more likely to be abnormal. In this scenario, we will transfer the abnormal embryo back, which may not result in a pregnancy. And if it did result in a pregnancy, it would lead to miscarriage. And again, at worst, result in a baby that's born with some form of genetic defect. Now, it's very important for patients who have mosaic embryos. They face a very difficult decision on whether to transfer or whether to discard. This is where the role in your IVF clinic, the genetic counsellor, and also your fertility specialist, together the 3 of you should sit down and discuss what to do with about the mosaic embryo. More recent studies have shown embryos that are mosaic that ended up being transferred have resulted in actually normal babies. What causes mosaicism? The list is quite comprehensive and it's actually growing all the time. There's a lot of research being done on that. This is just a brief summary of some of the causes of it. The take-home message is basically this: is there is no actual one direct reason why an embryo can lead to mosaicism, other than the fact that there's lots of reasons why. So now we can detect. Now we know about embryo mosaicism. So the next development, obviously, is the technology to be able to detect mosaicism, and that's the birth of PGS 3.0, the next generation sequencing. At the same time, the scientific community decided to drop the S and replace it with a T, which stood for testing. So it's now known as PGT. PGT encompasses all types of genetic embryo testing in the IVF clinic, with which there are actually three main types. The first type is what we call PGT-M, which stands for monogenic. This is where we screen for single gene disorders such as cystic fibrosis, Huntington's disease, thalassemia, Fragile X, and the BRCA1 and BRCA2, which are the breast and ovarian cancer mutations. The second type of test is the PGD-SRs, where we screen for translocations or inversions, where there are missing or extra genetic material in the chromosome, such as Robertsonian translocations. And the third type of PGD testing out there is what we call PGT-A, A standing for aneuploidies, where we're screening for extra or missing chromosomes. PGT-A is the most performed type of embryo genetic testing throughout the world. It probably occupies anywhere between around 90% of all known testing. I do apologise if I've used a lot of acronyms so far in the talk. The take-home message I want everyone to get is that the technology is now called PGT, and the most common type is called PGT-A. Okay, so the second part of my talk is to show some pictures and hopefully some videos of how we prepare an embryo for embryo genetic testing. Now, traditionally, PGT was performed by biopsy. In other words, removing cells from a cleavage stage embryo. That is, embryos that have been grown in the lab on days 2 and day 3. And that's highlighted by this, the little red circles. So this is the picture of an embryo on day 3, which has anywhere between 8 to 10 cells. So normally we will remove 2 to 3 cells from this embryo that we will send for genetic testing. As the world moved away from day 2 and day 3 transfers and started doing day 5 and day 6 transfers, in other words, transferring the blastocyst embryo, the trophectoderm, in other words, the cells that are on the outside of the embryo, which normally would form the placenta, was being biopsied. Today, this is the standard of what most laboratories do in terms of taking cells out of an embryo. Now, bearing in mind that whilst 90–95% of the world do blastocyst biopsy, there is a small number of labs that still do cleavage stage biopsy, in other words, embryos that are grown on days 2 and day 3. The main reason is that for cleavage stage biopsies, a patient can have a fresh transfer in the same cycle. I'll explain a little bit later in the following slides what that actually means. Now, the next video, which I'm hoping works, is what we call the hatching, which is where we have the embryo prepared for biopsy. And what we do is that we perform a laser on the embryo. I'm hoping that people can see this. Okay, now, so what is happening here, that little red circle is a laser. And what the laser is doing is that it's actually zapping the zona, which is the shell of the embryo. And the idea is that this is performed on day 4. And as the embryo grows on day 5 and day 6, that hole becomes bigger. And what we like to do is that's where we pull cells out of the embryo for genetic testing, which is shown in the next slide. So this next slide here occurs on day 5. The big, large mass that you see on the left-hand side is the actual embryo itself. And then the glass needle that is on the right-hand side, it's shearing or pulling cells away from the embryo. So what will happen in this scenario is that the embryo that is on the left, that will get frozen. And then the embryo, the cells from the embryo that are pulled, which is on the right-hand side, that will be sent to a pathology lab that will undergo genetic testing. Okay. So as I said before, the biopsied cells from that video that you saw, the ones that were pulled from or away from the embryo, that will be sent to the genetics pathology lab for next generation sequencing, and the whole remaining embryo is frozen and kept safe in the laboratory. So the results usually take anywhere between 10 to 14 days. And when the results come back and when the embryo is, the report says of those that are normal, that's the embryo that will be thawed out in a subsequent frozen embryo cycle. And as I mentioned before, the disadvantages of blastocyst biopsy is that you can't have a fresh transfer because the first part of the cycle is the creation of the embryo and the freezing of the cells. And when the results come back and that the results are normal, the patient will undergo a subsequent frozen embryo cycle where we will thaw out an embryo where the results are normal. Now, so that brings us to the final part of today's talk, which is the pros and cons of embryo genetic testing. The first part is that embryo genetic testing is ideal for patients who are carriers of single gene mutations and they don't want to pass it on to any of their future children. It's a great methodology for screening embryos so they don't have to go back. And the second advantage are for things such as chromosomal rearrangements or translocations. So that may result in either miscarriage or the birth of a baby with health issues. The third type of benefit for patients who want to undergo PGT is if they've previously had pregnancies that have been affected by chromosomal diseases such as Huntington's, Down syndrome or Turner's syndrome. Again, we can screen an embryo for these type of genetic mutations and only put back embryos that are normal and don't have these mutations. The other advantage that you have for PGT is that it's useful for patients who are much older. Usually for patients where the mother is older than 38 years of age. It's also useful for patients who have undergone recurrent miscarriages, and also if they've had multiple IVF cycles where they've had no success of embryos being implanted. PGT is a useful way to help screen for embryos for any one of those 6 categories that I've just described. So what's the downside of this technology? Now, the argument that I'm going to present forth today, I'm mainly going to talk about in terms of the disadvantages about PGTA, in other words, screening for aneuploidies, because I strongly believe that there is a place for patients who want to screen for monogenic disorders and translocations and chromosomal variations. In other words, these are the ones that we don't want in their pregnancy. However, the disadvantage for PGT is the screening to improve pregnancy rates, which many laboratories throughout the world are using. Now, the first argument is that the technology is not accurate. Strange you might ask that because we're now using PGS 3.0. The second is that there's a lack of evidence-based medicine for all patients who to be using PGT. And the third is, as you saw from a series of videos, PGT is invasive and it's also financially costly. In the first argument, I do apologize if I get a little scientific here. What it is an argument that's been put forth by many opponents as to why PGT is not accurate. Under the current guidelines, we would normally take about 5 cells from an embryo. What we know is that an embryo on day 5 and day 6 has anywhere between around 70 to 100 cells. So therefore, if we're only biopsying, in other words, taking cells from the embryos of only 5, then the overall representation of the embryo is as minimal as 5 and no more than 7%. So the question then is, how can we accurately make a clinical decision on the ploidy of an embryo when we only have as little as 5%? In other words, we're actually only sampling an embryo and not looking at the embryo as a whole. So the analogy I like to use is like during the last general election when we only polled a small population, and we all know what happened in the last general election. Norbert Gloister has proposed that we actually need to at least biopsy 27 cells at minimum in order to reach a minimal diagnostic probability. Now, the problem with Gloister's argument is that if you were to try to take 27 cells out of an embryo, you might actually not have an embryo left over to actually transfer. So in other words, what's the point of knowing about an embryo's genetic makeup when you don't have an embryo to put back? The second argument is that there is actually no randomized controlled studies showing that the current most evolved form of the technology, the next generation sequencing, has any improvements for patients who undergo PGTA. The most recent studies, the STAR and the ESTEEM study, published back in 2018 and 2019, have both shown that in general, PGTA did not improve pregnancy outcomes in all patients. Except in the STAR study, I have to say that there was a small beneficial increase in pregnancy rates for older patients, those that were between 35 and 40 years of age. The third argument, PGT is actually very costly. Patients need to be aware it's not covered by Medicare. As you saw from the series of videos that I showed, the process, the technique in itself is invasive, and at times an embryo may not survive the biopsying process, it may not survive the freezing process, and also it may not survive the thawing process. In other words, an embryo that might have been normal and transferred without any interferences from genetic testing is no longer available because it didn't it failed the biopsying, freezing, or thawing process. And what patients also need to understand is that PGT does not increase your chances of having a baby. In other words, if all your embryos come up as genetically abnormal, then the technology cannot improve on that in itself. So in conclusion, whilst PGT is not suitable for all patients, it could be beneficial for those patients that fall under the 6 categories that I explained before. In other words, those patients that have single gene mutations, they've got translocations, have had pregnancies affected by chromosomal variations, they're much older, they've had recurrent miscarriages, or they've had no success through the IVF treatment of about 5 cycles or more. Thank you very much, everyone.
Wow, I've learned so much, Khiem. Thank you so much for that, such an informative talk. I'm just in awe. So where I thought that, you know, if you did go down that route of testing, it would actually improve your success rate of implantation. That's what I actually thought.
Yeah, that's what many patients believe as well. But it all comes down
Wow.
to, like I said before, if a patient's embryos that have undergone genetic testing, if all their embryos come back as abnormal, then they don't have anything to put back.
Yeah, yeah. Wow, I'm just in awe. Okay, so can we screen embryos for sex selection?
In Australia, sex selection for family balancing is actually not prohibited. Is prohibited. It's only for medical reasons, for sex selection, for for patients who want to do genetic testing for the embryo.
Interesting. And is there a less invasive method of embryo genetic testing?
Yeah, thanks for asking that, Ella. Sorry. There is a less invasive version. It's what they now trying to coin PGS 4.0. And what this technique is what they call a cell-free DNA extraction, where they don't take cells from the embryo itself. What they do is that they analyze the metabolites that are excreted from the embryo, and they take the fluid that the embryo is growing in, and they analyze the DNA content from that extracted media. Now, at the moment, its accuracy has been put into question. It's nowhere near as accurate as the current form of PGS 3.0. In Australia, at the moment, there isn't any clinic that is offering this particular type of technology as a service. There was last year, but that has no longer been used at the moment.
So does that mean you'd have to take it, like to ship it to a different country if you wanted that particular testing?
I don't think also that in the world there are any laboratories that are offering this non-invasive version, mainly because of its inaccuracies. There's a much larger margin of error for non-invasive PGT compared to the traditional version.
So I remember, I'm not so sure, quite a few years ago now, that if you wanted to do genetic testing, you'd have to send it across to the States. Is that still the case now? Or
no, so many IVF clinics here have their own genetics pathology lab, and so within the cycle itself, on days 5 and day 6, the cells that are pulled out of the embryo will be sent to the internal pathology lab, and the patient will just have to wait for those results to come back, and then any results that come back that show normal embryos, they're the embryos that will be thawed out. So over the course of maybe from the creation of the embryo to putting back a normal embryo, you could potentially do that within 2 cycles, depending on how a patient stimulates in their frozen embryo cycle.
Okay, so we've got a question. Do you have to do genetic testing on both men and women before you do a PGT?
It comes down to what kind of test that you want to do. If it's screening just for normal PGTA, the answer is no. But if you're screening for monogenic diseases, then yes, both the male and the female will have to undergo genetic testing.
Okay, excellent. Do you have another? What happens to the embryo that is tested and the results come back as abnormal?
Yeah, so there's always an ethical dilemma when it comes to discarding of embryos where the genetic testing has come back as normal. I have to say that majority of the mutations that come back in the genetic testing is not compatible with life. So in the normal circumstances, these embryos are discarded, unless of course we are asked or requested otherwise by our patient that they would like to keep the embryo. But in general, the only mutations off the top of my head that are kept are the ones that are 21, 18, and 13. These ones are not normally discarded. We normally speak with the patient to let them know before they get discarded in the laboratory.
So, I mean, so in some ways, okay, right, it's especially if you've had recurrent implantation failures, and your embryo comes back and it's not so a grade A or
Yep.
And then sometimes the fertility specialist, even if they're a B grade, may just decide to transfer it. And so therefore there's loads of cases where you've had viable pregnancies and the babies come back normal. But so if those embryos that were of a lower grade were genetically tested, they may be discarded because maybe there's some sort of abnormality. Is that correct?
Yeah, so the embryo grading itself actually bears no relationship to the genetic makeup of an embryo.
Right.
I see this every day in the laboratory where the embryologist will grade an embryo an AA, and then the genetic result comes back, it's abnormal. Or vice versa, the embryo comes back as a BB, and the results are quite normal. What's most important is actually whether the embryo itself is able to be biopsied. And we make that decision based on, one, the stage of the embryo development on days 5. And if an embryo is not suitable to be biopsied, we'll grow it for another day longer on day 6. What we don't want to do there, Ella, is that we don't want to damage the embryo in the process of trying to pull cells out of it. And in that scenario, if we can't biopsy cells out of an embryo, a discussion will be made between the treating doctor and obviously the patient, and we'll let them know, we're very sorry, but if we try to biopsy this cell, we might damage the embryo. Would you like the embryo to be frozen, untested instead? So there's obviously options for a patient if that scenario was to take place.
Yeah. Does anybody have any more questions to ask Khiem? That would be great. Khiem, is there anything else that you would like to add?
Not on the top of my head.
No, it's been really great. I mean, it's one of these things where you have to think really carefully of whether you want to go down that route, or just let your body make it does its natural thing. So yeah, it's something to consider. Now, you mentioned that there's a counsellor when you had, I guess when you do decide to go for testing, that you have a counsellor involved. Is that correct?
Yeah, so for most normal genetic testing, discussion takes place between the patient and the doctor. You are correct, there is a genetics counsel available, especially for those patients who have translocations or monogenic diseases. And also the counsellor is also there to help assist with patients who want to make decisions on embryos that have come back as mosaic. So I like to think that every IVF clinic in Australia provides the bare minimum in terms of providing that genetics counselling service.
Excellent. Well, if anybody's got any more questions, if you just head on to the booth, and you could speak to the ladies there, and they could always book a time to see a genetic counsellor, or I'm not so sure whether you take appointments, Khiem, but there's but there's certainly, you can certainly talk to an IVF you can talk to a fertility specialist who will be glad to guide you through this decision. We're going to wrap up if there's no more questions, and yeah, if you've got any more, if you don't have anything else, Khiem, I think
I just want to say, at the end of the day, talk to your fertility specialist. They know what's best for you in terms of the pathway in the treatment cycle that you want to partake, whether it's a PGT or not. Yeah.
And it's always back to the referral of your doctor. I mean, together you can make that decision whether it's going to be suited or not for you. Okay, Khiem, well, thank you so much for your time.
My pleasure, Ella.
Knowledge. And speak to you soon. Take care.
Take care. Bye-bye, everyone.
Bye.